Now let us talk about the risperidone. Extrapyramidal features are more common with the typical antipsychotics, unlike the clozapine like agents. Risperidone is an atypical antipsychotic actually. So the thing is, if you compare clozapine versus risperidone, relatively the amount of extrapyramidal features will be much higher, but agranulocytosis is much more a common problem with the clozapine is what we need to fundamentally remember. But if you take the risperidone, it is less epileptogenic compared to the clozapine. Clozapine has more chance of causing seizures. And it causes the prolactin rising during the therapy, and it also can cause SADH. Another important problem with the risperidone is what need to be remembered. And let's go to the next question. What situations can cause hyperkalemia? Typically, ACE inhibitors, cyclosporine can cause renal toxicity. It can also cause hyperkalemia. Similarly, GM-CSF, which we use, granulocyte macrophage colony stimulating factor in bone marrow suppressed individuals, can also cause. Succinylcholine can cause. Already we discussed what are the different hyperkalemia, hypokalemia producing drugs. Dextron is a very important thing. No blood bank people are sleeping and no time for getting it. What is the immediate thing that you want to give for a trauma victim? Dextron is a plasma expander. But some problems are there with Dextron. Our blood groups, group A, group B, group C is not there, right? Okay. So O and all. Why one is different from other? Are they different proteins? Are they different carbohydrates? Are they different lipids? Basically carbohydrates, our blood groups are carbohydrates, not lipids or proteins. So there is a reason, Dr. Dextron also being a carbohydrate, polysaccharide, can cause difficulty in blood grouping and cross matching. And similarly there can be anaphylactoid reaction, and it can go and coat the platelets, and it can cause prolonged bleeding time, and also it prevents the Rulex formation of the RBCs. So that is the reason it has got an anti-sludging effect, and the advantage is in fact it can increase the microcirculation. So some good thing, bad thing about the Dextron we have to be sure about. Now on IV drug administration, elimination basically depends on what? We have to remember three important factors decide the elimination of our concepts and also of the drugs. We must be sure. Bioavailability, in entrance it must come to use, otherwise it is of no use at all. So bioavailability of our concepts is required, doctor. Second is volume of distribution. How long, how persistently we remember the concepts also is important. Clearance. If we only sit on one subject without reading the others, we don't clear them also, problem of toxicity can be there, right? So for drugs also all these three will decide elimination. So let us take up the next question. This is a very interesting, challenging question. 70 kg individual was given a dose of 100 mg per kg body weight of a drug, and its T half is 10 hours. Plasma concentration is 1.9 milligram per ml. Based on these values, calculate the clearance. So this test, do we know what is volume of distribution, what is T half, what is clearance, how do we calculate everything? One question can make us to revise the pharmacokinetics chapter, doctor. Basically what is clearance? It is amount of the volume of the drug which is being completely removed from the body for every unit time is called as clearance. Suppose if I say 10 ml per minute, it is the amount of the volume of the drug which is cleared from the body every minute. And this amount which is eliminated is proportional to the concentration of the drug in the blood. Naturally, more the concentration, more becomes the drug which is eliminated for every unit time. So there is a reason, doctor, clearance definitely depends upon the concentration of the drug also. Now what do you mean by elimination constant? Very simple. You have to take the concentration of the drug and time on x-axis, concentration of the drug on the y-axis. As the time passes, what will happen? The drug concentration keep on falling down. So then you basically calculate the logarithmic changes in that plasma concentration versus that of the time and calculate a value based on the slope of that graph called the elimination constant. So clearance is equal to that elimination constant which is calculated by the slope of the line of the logarithm of the plasma concentration versus time graph into volume of distribution. That gives you the clearance. Now what is the examiner trying to ask us, doctor? Clearance he is asking. Did he give the volume of distribution? He did not give. At least did he give the elimination constant? He has not given. So our job is to find out all of them, right? Now to calculate the elimination constant, if we know rate of elimination, that also helps us. What do you mean by rate of elimination? It is the clearance into concentration in the blood of that particular drug is called rate of elimination. I think rate of elimination was given here. It was also not given. Okay. Now here one concept comes to our help to calculate the clearance, that is called T half. Now what do you mean by T half? T half is the time which is taken for the plasma concentration to reduce to about 50%. After about 4 half-lives, nearly 94% of drug got completely eliminated from the body. So there is a relationship between the elimination constant and the T half. If we know T half, then we know how to calculate elimination constant. If we know elimination constant, then we can calculate clearance, provided we know volume of distribution also. So now let us get the clues. So elimination constant is equal to logarithm of the 2 divided by T half, 0.693 divided by T half. So because clearance is equal to elimination constant into volume of distribution, we can also say clearance is equal to 0.693 divided by T half into volume of distribution. So that is what we can derive. Now let us know how to discover then the volume of distribution. Typically it is the amount of the drug in the body which is administered divided by the concentration that it has achieved in the blood will give us the volume of distribution. Why volume of distribution is calculated like that? Very simple. Is the concentration in the blood is dependent on the volume of distribution? Definitely. Suppose if a drug has got a more amount of volume of distribution, can it achieve high or low drug concentration in the blood? Low. So it is inversely proportional to the concentration in the blood. That is the reason, doctor, volume of distribution is amount of drug we have given. More the amount of drug we have given, there is a greater chance of a bigger volume of distribution. That's the reason volume of distribution is the amount of the drug in the body divided by the concentration of that particular drug in the blood. That is how we can be able to calculate. Now is the amount of drug given is given in the question? It is given. And is the concentration in the blood achieved also is given? Then we know what is volume of distribution. And because T half is given, we can calculate 0.693 divided by T half and calculate the elimination constant. If we know elimination constant, if we know volume of distribution, we can also calculate the clearance. Now we are very sure how to answer this question. But before that, I like to tell you, those drugs which are highly lipid soluble, for example digoxin, what will happen? They penetrate the cell membranes and they will have a higher volume of distribution. Whereas those drugs which are lipid insoluble, like the neuromuscular blockers, they remain in the blood without going into the tissues, hence they have a lower volume of distribution, is what we have to remember. Now let us come to our question. So here the dose of drug given to the man is 100 mg per kg body weight in a 70 kg man. That means 70 into 100 is equal to 7000 mg, and that means 7 kgs. Is there any drug that we take 7000 mg is not 7 kgs? Oh, okay. It is 7 grams. That's what I was thinking. 7 kgs, what a drug will be there to eat like a candy. Okay. Still 7 grams also is high, doctor. 7 grams, which drug? Of course, aspirin in rheumatic heart disease, etc. You have to take voluminously. Alright, 7000 mg. Some of my students are better in their plus 2 in getting in medicine. Their ranks were far better than what I got. So I am sure 7000 mg is not 7 kgs, 7 grams. Good. So plasma concentration is 1.9 milligram per ml. Hence volume of distribution is 7000 mg divided by 1.9 mg per ml. Now clearance is 0.693 into volume of distribution, that is 7000 by 1.9, the whole of that divided by 10 ml per hour. So that becomes, take up the calculation, 4815 divided by 19, that is equal to 255 ml per hour, and that translates into 0.255 liters per hour, and one of the options given was 0.2 liters per hour, which is the closest figure. So that becomes the answer. So we finished physics also. Now let's quickly go to the next question. Tachyphylaxis means what? Repeatedly going to reading room makes us to not learn, is tachyphylaxis, right? So why does it happen? Rapid development of tolerance actually. That is still tolerance, right? Now inaccessibility of the receptor. If you are frequently using the drug, every time receptor will not say I will help you. Then fewer receptors synthesized. Drug is taken more commonly, receptors are available less. And desensitization is another important reason. Now let us look how the various drugs act. All of you know ephedrine and epinephrine. How does ephedrine act? It is a sympathomimetic drug. How does it act? Ephedrine will cause the release of the norepinephrine from the synaptic vesicle by stimulating it. That's how it acts. And then that norepinephrine will go and act on receptors. So it is an indirectly acting sympathomimetic which typically will cause more amount of release of the norepinephrine from the synaptic vesicles. That is the purpose of ephedrine, where it acts like a sympathomimetic agent. How about the reserpine? Reserpine basically will deplete this norepinephrine stores inside the vesicle. So if you combine ephedrine and reserpine, what will happen, doctor? Though reserpine is want to release, there is nothing available because though the ephedrine wants to release, there is nothing available because reserpine exhausted it. So that is the reason, doctor, if you give successive doses of ephedrine, its ability to typically affect the blood pressure become slowly diminished. Whereas if you use the epinephrine, however be the number of dosages, it still remains the same. And if you combine reserpine along with ephedrine, then reserpine blocks the effects of the ephedrine. So tachyphylaxis is generally a problem, especially with indirectly acting sympathomimetic receptors, because for an indirectly acting sympathomimetic effect, sympathomimetic agent, it need to have vesicle good, neurotransmitter inside that must be good, receptor must be good to receive that neurotransmitter. So many factors are there which are anywhere failure can be there, and on successive administration of indirectly acting sympathomimetic like ephedrine, tachyphylaxis will be there, is what need to be basically remembered. Which diseases have incubation period less than 10 days? This kind of questions actually make us sick in the exam, right? Which entrances have seats less than 2? Then how many days are you going to live if you fail in this entrance? These are all threatening questions in exam hall, but still we have to be ready to face this kind of questions. Cholera is few hours to 5 days, influenza is 18 to 72 hours, and plague has got 2 to 7 days bubonic, rubella 2 to 3 weeks, measles 10 to 14 days, at least some classical infections and their incubation periods we have to remember. Now isolation is done for all these highly infective conditions, measles, typhoid, TB, cholera, streptococcal pharyngitis, etc., etc. Now what does ORS contain, doctor? Glucose 111 milliequivalents, sodium 90, chloride 80, potassium 20, citrate 10, osmolarity of 311 is what need to be remembered. Then who are incubatory carriers, who are convalescent carriers, who are healthy carriers? Let us talk about it. During the incubation period only, people will be shedding their organism. Still clinical symptoms didn't appear in them. They are in incubation, but still they are shedding. Measles, mumps, polio, pertussis, influenza, diphtheria and hepatitis B belong to incubatory carriers. Convalescent, they recovered, but the clinical recovery is not the bacteriological recovery. They are still shedding the organism in spite of clinical recovery. Like typhoid, dysentery, cholera, diphtheria and whooping cough is an example of a convalescent carrier. Healthy carriers are those who are otherwise subclinical cases, they emerge from that, and they are typically poliomyelitis, cholera, salmonellosis, meningococcal meningitis and diphtheria, where they are not showing that sickness features, clinical features, healthy, but they are still remaining as the carriers and they are shedding out. That's the reason we have to give, in a subclinical case of meningococcal meningitis, rifampicin in order to remove the nasal carrier state of the meningococcal meningitis is what need to be remembered. MMR, I think, is a favorite question of all question banks. If there is one virus to detect, to hack their website and get those their respective question banks, life is much easier, right? So better learn hacking rather than what you call reading. That is a more easier way to get examiner's question bank, because you see, a Chandigarh exam you have MMR, AIMS exam you have MMR everywhere. That is the reason is government said students should know certain minimum things to the maximum way without any doubt. So that's the reason it becomes a part of what is the recent statistics, IMR value, etc. you must be sure about. So it is per 1 lakh population. Then DOTS is what? Direct observed therapy under supervision. So typically during the intensive phase, open the sachet, take the tablet, throw in the mouth is what has to be done. In continuation phase, you give tablets to home, but to give the second quota of the tablets, first quota tablets, this thing should be brought back. The multi-blister combi pack must be, empty one must be returned, and it is not continuous. Intermittent regime is the one which is typically used. Listeria gonorrhea can lead to urethritis, salpingitis, cervicitis, and also vaginitis. What is Rose-Waller's test, doctor? Basically, there is a suspension of sheep RBCs which are sensitized with the immunoglobulin G, and typically these factors can recognize the rheumatoid factors. So that immune reaction is observed in the case of Rose-Waller's test. Now, how do you describe the so-called rheumatoid factor, doctor? There are IgM antibodies which are directed against the IgG is what need to be recognized, and that these IgM rheumatoid factors are identified by the pre-sensitized RBCs of the sheep which are sensitized by the IgG of the rabbit. That is what is done in the case of the Rose-Waller's test. Yersinia pestis typically is a gram-negative, facultative, anaerobic, bipolar staining organism which has a safety pin appearance, and it can cause pneumonic and septicemic phases. What is safety pin appearance? You can see classically it is like a simple safety pin which we commonly use, Yersinia. It is a coccobacillus. It has got a fermentative metabolism, and it produces an anti-phagocytic slime, very characteristic feature. And is it motile or non-motile? One of the options was given. I mean, it is like a point blank questioning, motile or non-motile Yersinia, decide and get into the institute. So it is both actually. The point is it is motile when isolated, but it becomes non-motile in the mammalian host. So where do you want to talk about? So both the things are possible. It is non-encapsulated, and oxidase and urease negative is what has to be remembered. Which fungal infections in HIV, doctor? Pneumocystis carniae, cryptococcosis, mucocutaneous candidiasis, granulomatous hepatitis, and etc. etc. Now what is the odd man out here? You don't find mucormycosis, aspergillosis specifically in the case of HIV positive people. Where do you come across mucormycosis? Diabetic ketoacidosis. A patient comes with a black mass which is there in the typical nasal area. Then you have to think about mucormycosis, a fungal infection, almost synonymous with mortality unless you treat it very aggressively. Now, Epstein-Barr virus, what are all the conditions caused by it, doctor? Typically it is also called human herpes virus 4. Kaposi is human herpes virus 8, as all of you know very well. So nasopharyngeal carcinoma, Burkitt's lymphoma, which is a type of non-Hodgkin's, and the post-transplant lymphoproliferative disorder is also caused by the EBV is what need to be remembered. In fact, EBV is implicated in a lot of scenarios. Steven-Johnson, hepatitis, non-Hodgkin's, multiple sclerosis also they found a etiological role, and Kikuchi's disease. What is that, doctor? Non-specific lymphadenitis is called Kikuchi. When you join MD first year, you will have patient with a lymph node enlargement, and 4 to 5 lymph nodes are there. You have done, is there any caseous necrosis, is it there, is it a lymphoma, is it sarcoid, nothing is there. But there is inflammation within the lymph node, it is called non-specific lymphadenitis, which is called Kikuchi syndrome, is what need to be remembered. Then which are group B arboviruses, flaviviruses basically, West Nile virus, dengue virus, tick-borne encephalitis, yellow fever virus, they are all basically called Flaviviridae, is what need to be remembered. That's the reason Rift Valley and chikungunya do not come into the group B. So Japanese encephalitis is the one which is an example of flavivirus. Then which are spirochetal infections out of them? Anyway, you won't answer it as mycoplasma, I know that. Syphilis, you are sure, and you have that beautiful spirochete, leptospira, is another important one. And leptospira in fact can lead to Weil's disease, which is severe jaundice, renal failure will be there, patient goes into a comatose state and it is highly fatal condition. So the water contaminated with the urine of the infected animals is basically the problem in the case of the leptospirosis. There is a hemorrhagic problem in the kidneys is what need to be remembered. How about Legionella, doctor? It is those air conditioners, water coolers, they are the ones which led to a epidemic pneumonias in the west, which is called the Legionella pneumophila. Then how about the human plague? In fact, 1/3 of the European civilization was killed by not the invaders from Persia, it is by the plague bacillus. So bite of the infected flea is the one which is responsible, is what need to be remembered. Let us talk about the Legionella. Legionella typically can cause sporadic outbreaks, and it can be community acquired. It produces non-productive cough and low incidence of any purulent sputum, which is more characteristic of a bacterial pneumonia, I mean streptococcal, etc., etc. And Legionella does not form any spores. It has got a replicative cycle, and another one is called the infectious cycle, and it nicely goes into the phagolysosome and can be able to still survive inside it, is a very important feature. Now what are the extrapulmonary Legionellosis? What are the sites where you can come across? Heart is one important location, lymph nodes, spleen, liver and kidneys. And if you take the sputum sample, what is so characteristic about Legionella versus that of any other pneumococcal or any other lobar pneumonia? Typically numerous neutrophils will be there, but no organisms found. Then you think of, in that case of pneumonia, Legionella is a possibility. Whereas organisms are there, leukocytes are also there in the sputum, means you think of any other streptococci or pneumococci, etc., etc. And beta-lactams to which your regular streptococcal, staphylococcal are responsive, are not responsive to the Legionella, is not responsive, is what you have to remember. And it also can cause systemic manifestations. Hyponatremia is an important complication of the pneumonia caused by the Legionella pneumophila, is what need to be remembered. Now why Vibrio cholera happily loves and lives in the GIT, doctor? There are some advantages that it is having. Large inoculum size, acidic milieu of the stomach, though it is a barrier, still large inoculum size, and the motility of the Vibrio is important positive factor for it. Fimbriae which it is having, there are all the advantages. But is it susceptible to the acid? Very much. It is no exception, highly susceptible. In fact, what they found is if you give proton pump inhibitors, antacids, which are commonly given in the wards, it may sometimes, but not proven, can raise the chances of the Vibrio infection because it can survive in a non-acidic stomach environment. And it resists high alkalinity, that is advantage for the Vibrio, and it is still susceptible to heat, drying and acids, and it grows better in an alkaline medium, is what need to be remembered. That's the reason, how do you pick up the cholera stool, doctor? From that rubber tube, Venkataraman, Ramakrishnan medium and alkaline peptone water, etc., etc. That's what we have to remember. Now respiratory epithelium, which organism? It is a respiratory syncytial virus, can adhere, and there is a peculiar phenomena which the influenza virus will be showing. What is that called? Receptor mediated endocytosis is a very important special feature. It is the hemagglutinin of the virus which is responsible for it. It will fuse the endosomal membrane with the virus envelope. So we have to think of hemagglutinin which is contributing for this endocytosis. Now what does Enterobacter include? You have got the Klebsiella and E. coli, Proteus, not Pseudomonas. Pseudomonas belong to its own group, Pseudomonaceae, which is gram-negative rod is what need to be remembered. Now how is cholera transmitted? Food transmits it. Even healthy carriers who are not showing any clinical features, they also will be shedding. So that is how the cholera transmission can occur, fecally contaminated water and food. Chlorination, very effective against the Vibrio cholera, and that is very important. Now let us talk about the HIV. Latent phase of HIV, typically why does it happen? Why just like tuberculosis causes MON2 immediately, or hepatitis causes the serology positive immediately? Why the HIV has a latency? The reason is the clinical latency where the patient though has acquired infection is not symptomatic. The reason is typically it has got a it remains infective and it is replicating, and that's the reason he can still remain asymptomatic in the window period. So if you look at the typical graph, antibody to GP120 is a very important indicator of how well the virus is replicating. It slowly keeps increasing by about 6th week where seropositivity becomes possible. Around 10 years of average window period it continues, and similarly viral load also will slowly increase to its zenith by about around 10 years of later window period, and CD4 count also slowly comes down, and once you start antiretroviral therapy the viremia will come down spontaneously and CD4 count also will improve. Now which virus can affect the lymph nodes? Adenovirus is the one which typically causes infection of respiratory tract. We have adenoviral conjunctivitis. Intestine also, it undergoes a replication within the lymphoid tissue, which is a very characteristic feature, hence called as adeno. And even herpes virus HSV1, 2, they are capable of infecting the lymphoid tissue very much, and they are implicated in fact in some of the lymphoproliferative conditions. Herpes virus, human herpes virus is very much implicated. Arsenic, what are all the problems that can come across, that you can come across? There is a peculiar phenomena called Palmer hyperkeratosis, raindrop pigmentation can be there, hemorrhagic gastroenteritis can be there, Aldrich-Mees lines, and these are all important features. So these are classically the black marks on the hands and the feet. Almost it is looking like the 1000 pillar temple statues hands, right? So this kind of pigmentation can be there, and similarly there will be a lamellar desquamation of the fingers in the case of the arsenic poisoning, confluent brownish red papules, raindrop pigmentation in the friction prone areas, and there can be brownish red papules in groups in intertriginous areas, and Mees lines on the fingernails, and Buse lines with periangual hyperpigmentation. They are all the important features. Sin needles to kill the animals, where do you typically, how are they basically made? Abrus precatorius is the one which is used as a cattle poison to kill the animals. So toxalbumin is the one which is the active principle, which is as powerful as that of a viperine snake bite, is what has to be remembered. The seeds of it are called the rati seeds, and Suez are those fine needles prepared by decorticating the seeds and powdering them and mixed with opium, onion, etc., and typically they are injected under the skin to kill the animal. So Abrus precatorius, viperine, and cattle toxin, toxalbumin, they are all the buzzwords you must be sure about. Rigor mortis can simulate certain conditions. What are they? The heat stiffening when the body is exposed to temperatures greater than 65, and also cold stiffening can in fact very closely simulate the the rigor is what need to be remembered. Now maximum accumulation of arsenic where you come across, it is a liver where maximum amount is seen, and also even in the case of the kidneys and spleen. Black gunpowder, smokeless powder. What are the constituents of these two powders? Potassium nitrate 75%, sulfur 10%, charcoal 15%. We use some designations for these powders, just like Pond Supreme, Pond Super Supreme, Pond's Decent, Clear Cell Decent, different varieties. What is the importance? FG, FFG, FFFG. The more number of Fs, the finer will be the granules, faster will be the burning, and your patient will die. So that is the importance of more Fs, more killing power is what need to be remembered. So what is the gas released by the gunpowder contains, doctor? Another question. Carbon monoxide, carbon dioxide, hydrogen sulfide, methane and nitrogen, all of them are there. Then what are smokeless powders? Typically they contain nitrocellulose, nitroglycerine, all these things, and semi-smokeless also is there. So you have 80% of black powder, 20% of smokeless powder. I think we are learning too much about powders and guns, right? So but still no way we have to know all these things. Now which drugs are given in CRF? Should not be given. ACE inhibitors are the ones who you have to be careful if there is a bilateral renal artery stenosis. Spironolactone you must be careful because the potassium sparing diuretic. So already CRF is a state of hyperkalemia. Even amiloride is another potassium sparing agent which also can precipitate the hyperkalemia. Now hypercalcemia, what are the surgical causes? Once more, what a commonness. Recently we had AIMS November discussion 2007 also. Two causes you have to think, doctor, if there is hypercalcemia for your patient. One is hyperparathyroidism, second is malignancy. Without looking at that, you should not proceed further. There is a reason. Milk alkali syndrome, vitamin D intoxication causes increased calcium absorption, renal failure, decreased renal excretion, and increased PTH, malignancy, hyperthyroidism. They all cause bone resorption, release the calcium, leading to the hypercalcemia is what has to be remembered. Out of that, if it is a parathyroid adenoma, you can resect it. Multiple endocrine neoplasia, resect it. FEO, resect it. Similarly, breast, lung, kidney carcinomas as a paraneoplastic manifestation, for example squamous cell carcinoma of the lung, can cause hypercalcemic state. So they all can be resected, and thyrotoxicosis with a thyroid state can also be resected. Surgical causes for hypercalcemia. Now which tumors you can take care by chemotherapy, which tumors are not responsive to the chemotherapy? Out of all, the ALL, AML, Hodgkin's, germ cell neoplasms, pediatric neoplasms like Wilms, embryonal rhabdomyosarcoma, Ewing's sarcoma, small cell carcinoma, ovarian carcinoma, they are all the ones which are responsive to your chemotherapy. I think this list is longer. Let us remember the list which is not amenable to chemotherapy. That is the easier way, right? So pancreatic, renal, thyroid, biliary tract, prostate, hepatocellular carcinoma, melanoma. They are not that well responsive to the chemotherapy. But out of the options given, choriocarcinoma, embryonal rhabdomyosarcoma, highly amenable to the chemotherapy. Let us talk about their chemotherapy. Choriocarcinoma, what is that regime that we use, doctor? It's called IMACO regime. Etoposide, methotrexate, actinomycin D, cyclophosphamide, oncovin. IMACO regime is the one which we use for choriocarcinoma, highly responsive if you happen to identify and treat it, gestational tumor. Then rhabdomyosarcoma also, chemotherapy with surgical resection and radiotherapy for the local control. So for this you will be using cyclophosphamide, ifosfamide and etoposide in embryonal rhabdomyosarcoma. Let us talk about the maculopapular rash. Where do you come across? Lot of causes are there. Drugs can cause measles, rubella, erythema infectiosum, subitum, leptospirosis, dengue fever, SLE, malaria also can lead to development of maculopapular rash. At least as lesser mortals, let us review some of the conditions. Measles is a classical maculopapular rash. Erythema infectiosum also leads to this kind of a maculopapular rash. and in rubella you have the Fons-Schimmel's spots, and in rubeola also macular papular rash is seen. Autoimmune hepatitis. Typically, what is the serological profile of it? What are the types of autoimmune hepatitis? How do you differentiate one from the other? Anti-smooth cell antibody, also called AMSA. What is another AMSA famous for? American Medical Student Association. We don't have, unfortunately, HIMSA or IMSA, because the Indian Medical Student Association, they are not really that strong a body, right? In fact, MCA is a stronger body than us. So I think time that we also form one IMSA, like AMSA. AMSA actually is a very strong body. Anti-liver kidney microsomal antibodies called anti-LKM1. Then you have one of the options given, SLA antibody. What is the meaning of it? Soluble liver antigen antibody, which is directed against the cytokeratin type A and 18, which can be a potential question. Anti-SLA, I already gave it few years back. Why did you not check that? Against what is it directed? Did you not read and come? Can be a question in the next exam. So you must be sure. Cytokeratins. Similarly, liver specific acylo-glycoprotein receptor and hepatic lectin antibodies, anti-mitochondrial antibodies, any of them can become positive in autoimmune hepatitis. So you don't come across ANCA in autoimmune hepatitis. ANCA is found in vaginous, etc., etc. Now, the autoimmune hepatitis is divided based on the serological profile into type 1, 2 and 3. Common question asked in the exam is, where do you have this anti-liver kidney antibodies? You must answer like a parrot, type 2 type of autoimmune hepatitis. Then you are through the exam. Asthma antibodies and anti-actin are found in type 1, and synthetic core motif protein antibodies in type 2 along with anti-LKM. Soluble liver kidney antigen against the cytokeratins is found in type 3 is what we have to remember. Tell me, doctor, as a clinician, how do you come across autoimmune hepatitis? One of the challenging diagnoses, let me tell you, actually it is so dry to read like this, but it's challenging to diagnose and treat a patient. Somebody came with raised aminotransferases. Hepatitis B, hepatitis C, hepatitis A up to Z, everything is evaluated, nothing is found. Generally, if nothing is found, what do you suspect? EBV, CMV, hantavirus, even they are also negative. Then you are thinking, then why hepatitis is there? Are you alcoholic? Never, sir, no alcohol. It is not even alcoholic hepatitis. Then slowly your mind goes into autoimmune hepatitis. Then you will quickly get the profile done, serological profile. Then your anti-LKM antibody is also negative. Then still you like to consider autoimmune? Definitely. Autoimmune hepatitis, because it can be a type 3 where soluble liver and kidney antigen SLA antibody can become positive. So that's the reason, doctor, autoimmune hepatitis is a very common entity which you have to sure how to approach. Age also will help you. 10 years type 1, 2 to 14 years type 2, more often as a general medicine MD you come across 30 to 50 years type 3. Women more commonly in type 3, and other immune disorders will also be found in type 3. Sometimes SLE can be there, they also can have autoimmune hepatitis. And similarly, gamma globulin elevation will be more in the case of type 1. IgA levels will be there in low values in type 2. HLA association also they do differ depending on DR3, DR4 more often in the type 1. Steroid responsiveness, that is what we are interested, is typically found more often in type 1 and type 3, and progression to cirrhosis, that also we are worried about. It is much more common in type 2 where anti-LKM antibodies are positive. At least this much we know. We are ready to face a question on the autoimmune hepatitis. So thanks for the patient listening, doctor.